It's absolutely delightful to be here for this meeting of the Institute, the Roundtable on Health Literacy here in New York City at the New York Academy of Medicine. I want to thank Joe Ivey for having us here. I'm Dr. George Isham. I'm the chair of the Roundtable on Health Literacy. I like to tell people I'm not an expert on health literacy, but I'm an expert in convening conversations on health literacy. But I know we have with us today here in the room a number of real experts on that topic and real experts from around the globe. So it's really exciting that we have an opportunity to have a dialogue over the course of the day on health literacy and explore some of the challenges and the opportunities, as well as hopefully identify some next steps. So we are extremely pleased to convene this distinguished group of leaders to discuss health literacy policy and programs for improving health and health systems and health literacy around the world. I want to let everybody know that we are pleased that this meeting is being broadcast by webcast, by webinar rather, and is also being recorded and videotaped. So over the course of the day, we're going to want to make sure that everybody uses a microphone, even if you speaking in a manner that you feel that everybody in the room can hear you. Using a microphone will make sure that I understand the 400 or so plus people that may be listening on the webinar, which is a pretty good group, can also hear and participate in the proceedings, and that the videotape and recording can reach a much larger audience over time. I would like to thank Linda Harris and the Department of Health and Human Services for making it possible to provide this program via webinar. So Linda, thank you very much. So we're convening this meeting as the Roundtable on Health Literacy, which focuses on building partnerships to move forward the field of health literacy. As one of the major topics, the Roundtable sponsors workshops. As one of our major activities, we sponsor workshops for members and the public to discuss issues of importance and concern. And so a word about workshops. They're a little different than a consensus study of the Institute of Medicine where conclusions are reached and the group is very carefully chosen for balance. Roundtables are sponsored by those interested in the field, and we have a very diverse group of sponsors. And our activities, particularly roundtables, we will plan to make a report of this as well as the videotape available. And so, since we're not going to have a formal process for reaching conclusions, I urge all of you during the course of the day to be very explicit about identifying the challenges, the opportunities, and your ideas for next steps going forward. In that way, as we discuss those things over the course of the day, they can make themselves into our reports and our materials, and hopefully stimulate the connections between people and the dialogue that needs to occur to move this field forward. I will say that the Roundtable in the 7+ years of existence has stimulated a number of important activities here in the U.S., and I hope that'll be the case for this conversation on international health literacy. So we hope that this workshop will serve to initiate a widespread global dialogue among existing organizations and individuals about the importance of and the possibilities for health literacy efforts at many levels. Our workshop today was organized by a planning committee, and I would like to extend my thanks to the members of that committee. They include Debbie Fritz, Margaret Loveland, Clarence Pearson, Andrew Pleasant, Scott Ratzan, Will Ross, and Rima Rudd. So thank you all. I'm going to take this opportunity also to thank the IOM staff that's helped prepare this wonderful day here in New York. That would be Lila and your team, including in particularly Angela Martin, who's done just a wonderful job in making these arrangements for us to be here and have this conversation. So thanks for them too. So now we're going to begin the workshop with words of welcome from two distinguished colleagues, Dr. Joe Ivey Boufford from the New York Academy of Medicine, and Dr. Stephen Hoffman from the UN Secretary General's Office. And I'm going to introduce the two of them, read a little bit of some background for them, and then we'll have them provide a welcome to us. Dr. Boufford is president of the New York Academy of Medicine. She's also professor of public service, health policy and management at the Robert F. Wagner Graduate School of Public Service, and clinical professor of pediatrics at New York University School of Medicine. Prior to these positions, she served as dean of the Robert F. Wagner Graduate School of Public Service at New York University, and prior to that, served as the U.S. Department of Health and Human Services first and principal deputy assistant secretary for health, and then acting assistant secretary. While at HHS, she also served as U.S. representative on the executive board of the World Health Organization from 1994 to 97. And from 91 to 93, she served as director of the King's Fund College in London, England, which is a royal charity dedicated to the support of the health and social services in London and the United Kingdom. She served as president of the New York City Health and Hospitals Corporation, the largest municipal system in the United States, from December of '85 to October of '89. Dr. Boufford has been elected as membership of the Institute of Medicine and is currently a member of the Executive Council, the Board on Global Health, the Board on African Science Academy Development, and she was elected to serve as a second four-year term as Foreign Secretary of the Institute of Medicine beginning in July of 2010. So Joe is very qualified to start us off here. Mr. Hoffman is Assistant Professor of Clinical Epidemiology and Biostatistics at McMaster University in Canada, and serves as a fellow in the Executive Office of the UN Secretary General, where he offers strategic and technical input on a range of global health issues. A lawyer by training, and we won't hold that against him, Mr. Hoffman previously worked on, as a cross-border intellectual property litigator and has held several positions with the World Health Organization. He continues to advise WHO on their development of a global strategy for health systems research. In the area of health literacy, Mr. Hoffman chairs an academic advisory committee on health and science, reporting for Canada's only national weekly current affairs magazine. So we're very happy to have both of them. Joe, the floor is yours.
Well, good morning. As George said, I'm wearing two hats. I'll start off with my New York Academy hat. Let me welcome all of you to the Academy and many of you to New York. It's a bit of a crowded week to be here. Just stay away from the east side, from about 50th Street down to about 30th Street. You'll be okay. It's a real pleasure to have you here at the New York Academy, especially on this really important topic. I want to tell you a little bit about us. We were established in 1847 by a group of physicians in New York who wanted to improve the quality of health care. So we solved that one. And then we moved on over the years to be involved in some really important public health issues. We were very instrumental, this organization was very instrumental in establishing the Board of Health in New York City towards the end of the 19th century. We were active in establishing infant immunization practices, infant feeding practices, maternal mortality in the 1930s. We're doing it again this year, which is very sad. New York ranks the lowest, one of the lowest in the country on infant mortality, maternal mortality. The legalization of marijuana in the 50s, we were in favor of it. HIV/AIDS, needle exchange, substance abuse, a lot of work on policy, providing evidence for policy in terms of syringe distribution at pharmacies. And after 9/11, we're very involved in post-traumatic stress syndrome among school children. So we really try to work on some of the key issues, and our current priorities within the umbrella of urban health are healthy aging, prevention, and eliminating health disparities. And we work as a sort of think tank, do tank. We have research, we have policy advocacy, program involvement, and community engagement. We try to work on the kind of continuum that's represented by this very important meeting, which is global to local. An example of our current work, we've taken the World Health Organization model for an age-friendly city, and we've been working on it in New York City for the past 4 years, and really moving it from our own East Harlem community 3.5 years ago to aging improvement districts in 4 other parts of the city, and we're hoping to take that citywide over the next several years. Our learnings from New York have also allowed us to work with colleagues in other large cities, Philadelphia, Chicago, Oakland, who are taking on the age-friendly cities activity. We're one of our colleagues, Ruth Finkelstein, who's our Vice President for Policy, just returned from Tokyo and Taiwan, presenting the New York experience to the global age-friendly cities movement. And I think this is a really nice model. There's a terrific network. They signed something called the Dublin Declaration about a year ago, and really learning from each other, a global network of cities learning from each other how to apply the principles of age-friendly in their own context, which always is the key. Fundamental to age-friendly cities, and I would argue health literacy, is starting with the voices of older persons, in this case of age-friendly, but of the patient or the community. And we ask very simple questions. What makes it harder or easier for you to live an active and engaged life in your community? And that has led to major policy changes in the city of New York over the last 2 to 3 years. Some of the street islands that you see, benches on the sidewalks, traffic lights with timers that go more slowly so older persons can actually get across the street. And we've gone from one public pool with senior hours set aside in East Harlem, evaluating that demonstration, to 17 last summer, and every city pool will be have senior hours next summer. So it's an example of starting small from the voice of the individuals most involved and really making major policy change. This approach is fundamental to the Accountable Care Act, both at the patient level and at the prevention in the community-based prevention level. So your meeting is very relevant to U.S. policy, and the approach you've taken of really reflects also a fundamental commitment of the Institute of Medicine. We are working very hard to increasingly integrate the work of the IOM on the domestic side and the international side. Recently, the Council of the Institute of Medicine voted to increase the number of foreign associate members from 5 to 10 every year, and there will be an increasing policy effort to add international scholars to all of our workshops, roundtables, and peer-reviewed studies in areas of their expertise. Also looking at models for taking Institute of Medicine products, if you will, studies and workshops, and working with academies in other countries to apply it to their context when they're interested in those efforts, and some of those have been very successful. So what you will be doing today, I think, is a terrific paradigm, and we really hope that perhaps this may be, we can say that the New York Academy of Medicine was a venue for the beginning of a global effort to really develop a health literacy community from which we can all learn from each other and move this issue ahead. So welcome and enjoy the day.
Great. Okay, perfect. Great. Thank you to the organizers for this kind invitation to give a few introductory remarks on behalf of the Secretary General's office. Welcome to New York for those who are from out of town at this very exciting time of year. The high-level segments of the UN General Assembly begins tomorrow, and world leaders are descending on this city to debate some of the greatest issues facing our United Nations. There's perhaps no better time and no better place for the Institute of Medicine to host this important meeting on health literacy. As everyone in this room knows, health literacy is fundamentally a precondition for attaining the best possible health status and for mitigating health inequalities. From a global perspective, improving health literacy is also essential for achieving our collective aspirations and for making progress on the Millennium Development Goals. The way health literacy affects the 3 health-related MDGs is clear. Health-literate people are healthier people, especially when they're empowered to act upon the social determinants of health and to demand the fulfillment of their health rights. But health literacy also affects the other Millennium Development Goals. For without a sufficient level of health literacy, it will be impossible to fully eradicate poverty, to achieve universal primary education, and promote gender equality. Changes in our globalizing world are making health literacy more important than ever before. Cross-border trade and travel has reached unprecedented levels, continually exposing people to new threats and diseases which they have to be prepared to confront. Non-communicable diseases are increasingly taking the spotlight in our global agenda. Whereas infectious diseases were once our main concern, now the top 6 causes of mortality are high blood pressure, tobacco use, high blood glucose, physical inactivity, obesity, and high cholesterol, which together, according to the World Health Organization, account for more than 40% of all deaths. And as a result of this development, people are increasingly being asked to take greater responsibility for their own health and to make healthy decisions. But to do so, realistically, people need access to high-quality health information and the capacity to use it effectively. And this need was highlighted in last year's high-level political declaration on the prevention and control of non-communicable diseases. The United Nations is serious about promoting health literacy. For example, UNAIDS, UNESCO, and other key stakeholders launched EDUCAIDS back in 2004, which is an initiative that focuses on preventing the spread of HIV through education. As another example, UNICEF actively supports skills-based health education and focuses on the development of knowledge, attitudes, values, and life skills that children need to make the best health decisions possible. The World Health Organization is helping member states to use new e-health technologies, and the Pan American Health Organization is implementing a regional e-health strategy and a plan for action for all countries in this region. Like the UN itself and all of its agencies, the Secretary General himself is also serious about health literacy. For example, last week, instead of meeting prime ministers or presidents for his first bilateral meeting of this General Assembly session, the Secretary General chose to meet Kami, an HIV-positive Muppet from Sesame Street. He did this to raise global awareness among children for HIV and the challenges facing people who live with HIV. The Secretary General is very committed to global health issues on a personal level. Guided by the Millennium Development Goals, he has focused much of his efforts over the past few years on advancing health of women and children through his Every Woman, Every Child initiative. I think we can all agree that improving health literacy among women and children is particularly important. Women and children are often the most vulnerable members of our society and face the greatest levels of poverty and discrimination. They often have fewer opportunities and have the most to benefit from health literacy initiatives. Efforts targeting women and children are also perhaps where we may see our greatest successes, both for health, but also for other goals. For women and children are in many respects the engines for development, for economic growth, for social well-being, and for sustainability. And as the Secretary General often says, where women and children are empowered and educated, economies are productive and strong. Where women and children are more fully represented, societies are more peaceful and stable. And I would add to that quote that women and children probably represent our world's greatest untapped resource. But to conclude, we obviously cannot only think about how health literacy may change the world, we also must think about what the changes in our worlds mean for how we deliver health literacy initiatives. Today's world has the largest proportion of young people ever. We need to think creatively about how to reach this crowd, appeal to their tech-savvy ways, and empower them with choice. Technology will no doubt be a key facilitator of health literacy. 3/4 of the world's inhabitants have access to a mobile phone, which is a greater proportion of people who have access to essential medicines. Both traditional and social media are also crucial for health literacy in this new era. We must bridge the gap between what we know about health issues and how the news media covers them, and we must unleash the health-promoting power and potential of Web 2.0, the blogosphere, Twitterverse, and whatever online spaces become popular tomorrow. Ultimately, we need to continue thinking about how these technologies and platforms can be used to improve health literacy and accelerate progress in global health. This is important work, which I'm sure will keep us all engaged and busy throughout the day, and I look forward to being part of these discussions. Thank you.
Thank you very much, and I want to express my appreciation to Ivey Boufford for that welcome. We've had the chance to be here in this wonderful room and be reminded of the history of the New York Academy. Some of us have had the opportunity to walk here this morning from the hotel and experience some of the health-friendly features that you talked about in New York. And for someone from Minnesota who always is a little anxious about going to New York in the beginning, it's wonderful to be here. So thank you for that warm welcome. And thank you for those kind indications of the direction of the Institute of Medicine in broadening its global reach and engagement. And really appreciate, Mr. Hoffman, your comments about the interests of the Secretary General and the importance of health literacy in terms of the broader agenda of the United Nations. I think that sets a very good context and challenge for our comments for the rest of the day. So let's now transition to the next panel. And as we do that, I'm going to ask the next panel to come up here and take your seats at the head table. Thank you so much. And while they're coming up and assembling and getting set, I'm going to begin the introductions and make sure that, that they're properly introduced. We're going to now do a panel on health literacy perspectives. They will provide their perspectives on health literacy, and I'll introduce all of the distinguished speakers at this point. I will then ask you to hold your questions, and I'll ask the presenters to make their presentations within the time we've allotted here. And then we'll have a period of discussion if we stay on schedule to where we'll engage. And that'll be our pattern throughout the day. So as you'll notice from the agenda is very tight with respect to the ambition of the Planning Committee, with respect to the amount of information that we've wanted to get into the agenda. So it's important we stay on schedule. So we'll try to do that. First on our panel will be Dr. Jacob Kumaresan. He is currently Executive Director of the World Health Organization Office at the United Nations here in New York. Earlier, he was Director of the WHO Center for Health Development in Kobe, Japan from 2008 to 2011, and President of the International Trachoma Initiative, a nonprofit organization dedicated to eliminating the leading cause of preventable blindness from 2003 to 2007. Dr. Kumaresan, I'm sorry if I've got this wrong. I apologize. Joined the World Health Organization headquarters in Geneva in 1992, where he eventually headed the Stop TB Partnership, expanding efforts to meet the global targets to stop TB. He has a widespread public health experience and has worked with the governments of Zimbabwe and Botswana during the 1980s. Second on the panel is Dr. Scott Ratzan, who's Vice President for Global Health at Johnson & Johnson and Editor-in-Chief of the Journal of Health Communications, International Perspectives. He's also co-chair of the United Nations Secretary General's Innovation Working Group on Women and Children's Health. He also serves on the World Economic Forum's Global Agenda Council on Health and Well-Being. Dr. Ratzan is co-author of the definition that serves as the basis for U.S. efforts in health literacy and is a member of the U.S. Institute of Medicine Roundtable on Health Literacy, our group, and we're very grateful for his engaged leadership on our group here. Prior to joining J&J, Dr. Ratzan was Senior Technical Advisor in the Bureau of Global Health at the U.S. Agency for International Development, where he developed the Global Health Communication Strategy for U.S.-funded efforts. He spent a decade in Boston in academia as founder and director of the Emerson Tufts Program in Health Communication, and in 1998 moved to Washington, where he worked at the Academy for Educational Development on Domestic and Global Health Policy and Innovation. He currently maintains faculty appointments at Tufts University, at George Washington University Medical Center, and the University of Cambridge Judge Business School. For those of us who know Scott, we wonder how he can be everywhere at once, but he manages to do that. Third on our panel is Dr. Cynthia Baur. She's Senior Advisor for Health Literacy in the Office of the Associate Director for Communications at the Centers for Disease Control and Prevention of the U.S. Department of Health and Human Services. She chairs the CDC's Health Literacy Council, manages the CDC Health Literacy website and blog, and also she was one of the developers of the CDC's online health literacy planning for health professionals. From 2006 to 2010, Dr. Baur was the director of the Centers for Disease Control Division of Health Communication and Marketing in their National Center for Health Marketing. She's also co-chair of the Healthy People 2020 Health Communication and Health Information Technology Work Group and co-chair of the HHS Work Group on Health Literacy. She is a lead author on the National Action Plan to improve health literacy here in the U.S. Next on the panel is Ms. Jennifer Cabe. She leads strategic and operations functions for the Canyon Ranch Institute, a not-for-profit public charity that works with its partners to help educate, inspire, and empower every person to prevent disease and choose a life of wellness. Partners include the Clorox Company, George Washington University, Live Strong, and the University of Arizona. Previously, Ms. Cabe served as the U.S. Office of the Surgeon General as Communications Director and speechwriter for U.S. Surgeon General Surgeon General Richard Carmona. And in that capacity, she developed the health literacy initiatives with advocacy groups, community leaders, health professionals, policymakers, and the public. Ms. Cabe has been awarded the Surgeon General's Medallion and the prestigious U.S. Department of Health and Services Honor Award for her role in developing the U.S. Surgeon General's Family Health History Initiative. Prior to joining the Office of Surgeon General, Jennifer was Communication Officer at the Fogarty International Center at the National Institutes of Health. She is currently a member of the faculty of Ohio State University College of Nursing and serves on the advisory board for Time to Talk, Cardio, online health literacy program that received the Institute of Healthcare Advancement's Health Literacy Innovation Award for 2010. And then we have also Ms. Suzanne Thompson, Vice President of Research and Development for the Clorox Company, and currently leads the Global Stewardship and Innovation Group. In this role, she leads technology design, corporate innovation, product stewardship, and regulatory efforts. Prior to her current role, she led the Cleaning Division Research and Development Group. She's been working on the consumer packaged goods industry at the Clorox Company for the last 26 years in research and development, and she has experience in process development, product development, and packaging development for divisions such as the Kingsford Charcoal, Laundry, Home Care, Auto Foods, Litter, and Professional Products. So I'd like to welcome all of you to this panel. As you can see, we have a rather diverse and capable group. Each will have 15 minutes. As you know, we try to enforce that rather strictly, so those of you speaking later should watch this, see how successful we are. Lila, who's sitting right down here, Lila Hernandez, has a series of signs, and we hope to enforce that. And the reason for that is simple, because we've got a packed agenda, we want to hear everybody, and the process of the roundtable workshops is such that we need to have time for discussion in order to make sure that we get the ideas on the table. So we will enforce that. So let's start out.
I just click this one.
Just 1 second. You can do it either way.
Good morning, everyone. Great time to be in New York, isn't it? Okay, I want to say that this is a fantastic opportunity for me to talk about health literacy with the World Health Organization. And I commend the organizers because it's also a nice time to celebrate the UN Literacy Decade, which is 2003 to 2012. So the work which you're doing is very important and should feed into this UN Literacy Decade. So let me start with some definitions. This is the Health Promotion Glossary of WHO 1998. It says that the cognitive and social skills which determine the motivation and ability of individuals to gain access to, understand, and use information in ways which promote and maintain good health. And what's the purpose of this? It implies that the achievement of a level of knowledge, personal skills, and confidence to take action to improve personal and community health by changing personal lifestyles and living conditions. And this is important. It's just not passing on information for the sake of passing it on. Now, health education aims to influence individual lifestyle decisions, but it also raises awareness about the determinants of health. And it's achieved through methods that go beyond information diffusion and requires interaction with the individual, participation, and critical analysis. Health education must lead to health literacy, which then empowers individuals, the family, and the community. And it goes beyond the narrow concept of health education and individual behavior-oriented communications, and must address the social, environmental, and political issues. It also is a tool for empowerment, and it empowers people to take control of their health by helping them to properly use the information which is provided to them. This leads to personal and social benefit, enabling community action and continuity to social capital. And so we believe that it's a means to social and human development, as was outlined by the speaker, Stephen, who talked about the Millennium Development Goals. By improving people's access to health and information and the capacity to use it effectively, health literacy is critical to empowerment. And more than, it's just not about reading pamphlets and being knowledgeable about that, but and in order to have this kind of an effect, you need to have a very effective and efficient communication strategy. I'll outline some of the challenges which we face today. The health literacy level is low worldwide, and there are two sides to the coin. One is there's a low level of information, but there's also an overload of information. Let's start with the low level of health literacy. Low level of literacy means that they have less access to internet and online information, and they may not be able to evaluate all the quality of information from the different sources. Also, these kind of people have lower utilization of preventive services and tend to use the treatment services more, thus burdening and having an economically high cost for the healthcare system. On the other side of the coin, there's health information overload on the internet, but there is lack of enough evidence-based information which is easily available to the general public, and it's difficult for consumers to understand and evaluate the accuracy of all the information they had. And there is no standard quality check. Any kind of information is available. The level of health literacy in many developing countries is unknown, and this is very unfortunate. You may hear later in the day that there is a European health literacy survey which was done, but it's only for the European countries. But mostly in Africa and Asia, there's very little information on health literacy. And also some of the challenges are language barriers, which we are all familiar with, and cultural issues which need to be taken into account. Now I'll go on to see what are some of the strategies which can be used for effective health literacy. Communication action should be the key component of what we do in health literacy. And in order for that to be helpful, we need to have a well-functioning, rights-based, patient-centered healthcare system. And the third aspect is that we need to have multi-sectoral collaboration at the national, regional, and international levels to be able to overcome the inequities. And I'll give you an example of that. This graph shows the gap in non-Maori and Maori life expectancies over a period of 55 years in New Zealand. And as you can see, in both male and female, the gap was quite high, about 14 and 16 years, and came down by half in over 50 years. But still, the gap exists. But in order for that to be achieved, the government had to take some serious whole-of-government approach, policy approaches, very strong leadership from the Ministry of Health, and increased expenditure in health services, but most importantly, local intersectoral actions. It was actions taken for the Maori, by the Maori, And this was important to have this kind of a drop. We also need to have universal access to health services, which will ensure that all people have educational materials available to them. And educational programs need to be not only from the health sector, from the clinics and hospitals, but it also should be in other places such as schools, colleges, workplaces, libraries, which are institutions that can offer programs to increase public health literacy rates. And finally, we need to have innovative and proper use of ICT technology to bridge the health literacy gap and pass on the information using the new tools which we have available today. One example of that is the mHealth Tobacco Cessation Project, which is a program of WHO along with the International Telecommunications Union, where they use mobile phones for awareness of risk factors, screening, and citizen reporting. These SMS-based services have also shown that it can be very effective in reducing the number of smokers quitting, and in a publication in Lancet, it was said that in 6 months, the quit rates were double as compared to the control population over a group of 5,000 people who were using these interventions. I now want to talk about the Non-Communicable Diseases program. Again, it was alluded to by our previous speaker. This is one of the highest burdens today. More than 60% of the burden is due to non-communicable diseases. And it's not a developed country issue. It is a developing country issue, more a developing country issue, because the number of deaths from people less than 60 is much higher in the developing world as compared to the developed countries. And therefore, most of this can be prevented. And this is the reason why last year, for only the second time in the history of the United Nations, health issue was discussed at a high-level summit attended by the heads of state. And there was a political declaration which needs to be implemented in the coming years. Yeah, empowerment using mobile health can be a very easy way to go. We can harness the technology to provide sustainable, scalable, cost-effective solutions for key NCD risk factors. Text messages can increase for the use of people using sunscreen. It can improve the compliance of management of diabetes. It can encourage the use of condoms, and they can use sensors and mapping in order to track use of inhalers by asthmatics. So there are many, many mechanisms by which we can use mobile technology. And all of this is intended to have a constant application of the message so that you can have behavior change initiatives through these mechanisms. It's so difficult to do face-to-face communications on the same issue, but I think sending a text message or an MMS will be fairly easy. Now, why is mHealth so important? As you can see in this graph, this is statistics from the developing countries. The reach is so much vaster. If you use hospital beds, it reaches only 11 million people. If you use computers, it's 305 million people. If you use mobile phones, it's 2.2 billion. You can see that the outreach is dramatic. In February 2012, BBC stated that the mobile devices will outnumber the number of humans this year. But interestingly, 2 out of 3 mobile phone users are in developing countries. And if you look at the people in the rural areas, 50% of the people have mobile phones. There's an ubiquitous outreach of mobile phones, and today the global coverage is 7.4 billion, and in 2016 it's expected that there will be 10 billion mobile connected devices around the world. Why wouldn't we use that technology? Let me give you an example of how it is being applied in one of the villages in my country, in a state called Bihar. There's a program called ComCare, where mobile phone application is used as a tool for counseling adolescent girls and on menstrual hygiene, on STDs, and family planning methods. This is a rural development program undertaken by the civil society but supported by the Ministry of Health. We think that people in the rural areas are disempowered and helpless. It need not be so, because they can be reached. There are a couple of examples here of health literacy in action and what it can actually do. One is on a breastfeeding program in the Philippines, where there was a national plan for information campaign on promoting breastfeeding. And this not only increased the breastfeeding, but saw a decrease in infant mortality rate. Another one is on malaria in 8 countries in Mesoamerica, where there was a national environmental campaign on community cleaning of neighborhoods. And this was to keep the environment clean without the use of DDT. So in the homes and patios and surroundings, people cleared the collected waters and covered the water storage containers and managed the drain systems. And they organized community cleanings in the neighborhoods, including the streets and the forest areas and the swamps. What it saw is that in 2 years there was a reduction in vector density and a 63% reduction in malaria cases. The reason why I'm saying this is that these need to be tracked, and we need to have good measures. Without measures, we won't be able to track these activities. Lastly, I'd like to show some of the WHO activities on health literacy. As I said, we do work with many UN partners, ITU being one of them. And we launched in February of this year a National E-Health Strategy Toolkit to help governments to develop the e-health strategy. And each government needs to do this. It needs to be an action plan with a monitoring framework, and WHO assists the governments to do this kind of health literacy plans. This is one of the models of our e-health infrastructure. It can very quickly access health information, but also provide and manage health and well-being by monitoring and managing the medications. We can access the records, either personal records or medical records, and it can also have automated dispensing of medication through pharmacy services. And lastly, there can be an interaction with the care providers and remote monitoring. So this is a kind of a system which can be built, and this is one of the models which we are using. I want to say that also our regional offices are very closely involved in this, and in the case of our European region, their programs are very much empowerment focused, and there are 3 programs which are in this kind of a strategy. One is the NCD prevention program to supply information and tools to prevent and manage NCDs. Another one is on a new mental health strategy, where the heart of the strategy is to empower people. And a third one is on patient safety, focusing on patients' rights and safety around the themes of blood transfusion and hospital infections. And all of this is that we need to avoid this kind of a situation where people are not baffled by the numbers we provide, but they can have a better understanding of what we are talking about. Thank you very much.
Great. Good morning. Thank you, George, for the introduction, and I really like to first thank the Academy here. It's great to hear the New York Academy of Medicine is actually older now, I learned, than the National Academy of Sciences, and then, of course, the Institute of Medicine that was born some time ago. I think there's a lot of great history where we've been, but more importantly, where we can be going with health literacy. So it's certainly humbling to be here amongst experts who have introduced me to this field some time ago and helped develop it in many ways. So I hope over the next 15 minutes to go through a number of the ideas, touching on some of the pieces that Jacob mentioned, certainly that Stephen mentioned with the work at the United Nations Secretary General's office, and bridge some of the areas from both the academic, public health, communication, health literacy fields. I always like to start with the preamble of the Constitution of the WHO, that informed opinion and active cooperation on the part of the public are of the utmost importance in the improvement of health of the people. And so much of what we need to do is aimed at how do we improve this. So I believe health literacy has great potential. A lot of work we've heard, certainly here in the United States, that many of you have been engaged with, the United Nations pieces that we've heard about. We've published quite a bit in the Journal of Health Communication over the last 17 years, and a number of action guides that Dr. Apfel's put together you'll hear a little bit about later. But when I've been presenting this, I have stolen, if I can say, I've taken Ruth Parker's slide and say this is a pie-in-the-sky idea. How can we really move health literacy in a way that will make a difference for everyone? And even this pie in the sky is not culturally sensitive around the world. When I presented this in Brussels, and I could ask Ilona how this translates in Germany, but I know that it didn't quite work in some cultures. But it does remind us that this is a big idea, and it's something that's going to take a lot of time in marshalling forces. So as you know, years ago, Ruth and I and Marcia Zorn from the National Library of Medicine and Catherine Selden and others did a current bibliography of medicine. And in the review, we retrospectively looked at all the articles at that point that were published on health literacy and came up with this definition. And just simply, now that we're hearing more mobile, important to obtain information, process information, understand information, and make appropriate health decisions. Key to this definition also is it has services in there, and so much of what we do is also how we deliver health care and what this means to the future. And as you see, this is part of the Affordable Care Act, and I won't be going into depth here today, but there are specific activities that you'll hear later, perhaps from Cynthia next, on where this fits in the United States. This is the framework that Ruth has presented. Just to remind, and I think it fits well with what Jacob just mentioned, on the left, many people think is what health education and the individual level on skills and ability, and on the right's the healthcare quality discussion. How do we simplify the demands and complexity of the system? And health literacy is that space in the middle. Well, fortunately, there's been a number of discussions on health literacy that have gone beyond New York, Brussels, Geneva, and George and I were at a meeting in Beijing that the United Nations ECOSOC held on promoting health literacy. It was the first UN meeting that I know of on this. And months later, the Chinese health minister stood up in Geneva, and this declaration was made at the ministerial level. We stress that health literacy is an important factor in ensuring significant health outcomes, and in this regard, call for the development of appropriate action plans to promote health literacy. This was the beginning in 2009, and as you heard from Stephen, 2 years later, the first time ever on non-communicable diseases, only second time convening on health issues, there was a highly negotiated number of recommendations that came into play, and this was one I think that was most key on health literacy, to develop, strengthen, and implement as appropriate multi-sectoral public policies and action plans to promote health education and health literacy, including through evidence-based education and information strategies and programs in and out of schools and through public awareness campaigns. I say this is key for anybody in the UN area. This was not only supported by Switzerland, United States, G77, European Union, but very specific on the language of not to make health literacy the same as health education, and also to remind that health literacy is not just what's done in the schools. Well, that might work for MDG 2. It's not necessarily only going to be based in schools, so in and out of schools and the public awareness campaigns. It goes on to say from some of the work in Australia and others that Don may mention that some of these are in early phases. So a lot of this now is how do we implement this non-communicable disease action plan to try to have a 25% reduction by 2025. The European Union at the same time had a European Union high-level pharmaceutical forum. I was able to be a part of that, and that's where I also enjoyed learning about health diplomacy really in action as both an American and a private sector non-representative. We certainly worked hard for getting health literacy there, and clearly this is the key. I think the final term is just promoting health literacy and health information in the broadest sense. And this is something we'll hear later, I think, from Christine about the work that's been done in the European Union as well as Switzerland being added to that mix. It's a U.S. priority. We have heard from Howard Koh, other assistant secretaries here, and the action plan has some of the key areas. I think probably the best piece, and thanks Cynthia Brock and AHRQ and all the other ones who've been engaged, is to remind us that health literacy is important to make health reform a reality. And without health information that makes sense to them, people can't access cost-effective, safe, and high-quality health services. And in this regard, we have a lot of work being done with Len at HRSA and others around on how we can actually make this health reform a reality. So clearly, you know, we have these policies. Taking, again, the model, how do we work with both consumers and patients? And I separate those two out, and how do we simplify the system? So this is a slide that has some ideas of the different pieces of what's being done globally, internationally, and national momentum. On the far left, we've heard already about the National Action Plan to improve U.S. health literacy, the ministerial declarations that are there at the UN, which means every member state has signed up or agreed to some of those actions, the European Union resolution, and right now some member state actions that we'll hear more about. There have been a lot of public health advances, and health literacy coalitions and public-private partnerships are really growing here in the United States at the state level. Andrew and I last week were at New Jersey Health Literacy Coalition. We have Missouri on our roundtable. There's a whole variety of these. I think 24 states have activities at this juncture, and many more are developing these at both the state, city, county level, not to mention the regional ones in different parts of the world. The health communication and literacy is integrated into health professional training. I know not only the HRSA work, but UMDNJ and many others. The competencies for the 21st century medical training, with the MCATs, the medical entrance exams for in the United States changing, behavioral and social sciences are going down to the undergraduate level. There's health literacy opportunities there. And then finally, how the non-communicable disease is linking with agendas. And on the far right, I put private sector programs. We'll hear a little bit more about. These may be private sector programs led, such as health checklists or scorecards, but these are also private sector engagement and workplace. Clearly, while the private sector is a workplace, still the largest employers are, in many cases, of course, governments. And then finally, I think we need to continue to have more campaigns and innovations. And the mHealth piece has already been presaged quite well from Jacob in the slides that he showed of where the WHO and ITU and others are looking at this new area. So the work that I've been doing with the Innovation Working Group this past year, now 2.5 years, has been focusing on how we come up with innovations both in the mobile health space and other spaces where people are delivering health care, both in and out of homes, as more than 50% of births in the world are actually not in a healthcare facility or with necessarily trained health professional. So we've been looking at checklists and scorecards, and the next number of slides I'll be showing some ideas that I think have applications specifically for health literacy. And these build upon the work by Atul Gawande, who's a professor of public health and surgery at Harvard. And just recently in the New York Times, I think this was a very good article talking about our longing for lists that just really talked about the culture of how we've all grown up of using checklists. And this is actually a checklist of Johnny Cash that they put in there of what he was doing years ago, what he needed to do. But it's highlighted the work of Atul, and in the last year there's been a whole number of pieces of why people, in this case the United States, people culturally would adopt lists very well. Zeke Emanuel wrote in the New York Times the use of checklists saving as many as 28,000 deaths in intensive care in the United States on the use of the ICU checklist, the insertion of the intravenous catheters checklist. And in the Lancet just recently, looking at checklist as a frugal technology. Everything doesn't have to be high-end and expensive, but the 29-item safe childbirth checklist that's been developed in India already is moving very positively in this direction with an article that Jonathan Spector published in May this year. So these are the checklists that I've been finding, because we're an evidence-based, theory-based, science-based group here at the Institute of Medicine. These are the ones that have the best evidence to date. And frankly, all of these are aimed at the learned intermediary or a health professional or a health worker. The central line ICU checklist, simple 5 points. As I mentioned, 28,000 deaths in the U.S. This has really found its way into a whole variety of activities around the world. The surgical safety checklist, this global rollout continues. And what's most interesting, it also empowered the whole surgical team. So it wasn't just the surgeon who partakes in it, but the surgical team to ask the questions. And that's made a huge difference and continues to be really the proof of concept that what we've learned in aviation, what we've learned in manufacturing, what we've learned in engineering can be applied to healthcare. The Safe Childbirth Checklist is the one that's been in India right now, and the Harvard study has basically shown that this program works. Those in communication might say a 29-item checklist is too long, but they have shown that there is movement in the right direction, and this is being scaled there. And I think I can presage later in this week at the UN Commodities Commission report on life-saving commodities, they will be mentioning the suggestion to scale this up in at least 5 countries within the next year, and all every woman, every child countries in a number of years. So we believe that there's great opportunity here. The 7-day tool is 7 days postpartum. That's the first MCheck tool also developed by WHO. So we published this report that's coming out tomorrow. I served as editor with Jonathan Spector at Harvard of the potential for checklists, what we call for the last kilometer. And our group, which included not only Atul and WHO and other folks, have come up with the idea that checklist programs can work in different ways. I have some of these available. It will be posted on the WHO website. But what our task force came up with is we can come look for other areas, such as birth preparedness. There's nothing that exists for a checklist in the last 30 days for women during pregnancy, also for her family or carers or caregivers. So we think there's an opportunity there, and there's other places that we put in the conclusion that health literacy can make a difference, not just for the health intermediary, but for the individual patient or consumer, and that's where mHealth is so powerful. The Institute of Medicine had a meeting a few years ago, our roundtable on health literacy, e-health, and communication, putting the consumer first, and that helped spur many ideas that then I later wrote an article on a checklist for non-communicable diseases that has developed. In the interest of time, I'd like to move, okay, how do we take these innovative ideas and how do we make them practical? How do we really move that? And as we know, sifting the evidence for sound studies with the take-home message is laborious and the yield disappointing. We have to take many shots on goal if we want to actually have something to be successful. And I believe there are a number of innovations with checklists and scorecards that can help with health literacy. So the scorecard idea actually came, I could thank Marcia and the National Library of Medicine. I gave a lecture in 2000 called Quality Communication, The Path to Ideal Health. And I looked at Martin Rees, who wrote a book on just 6 numbers that explained the science of how the universe came. And I thought that why don't we do this, just the 6 numbers that we could have something for health. And in the midst of that, reporting of numbers and health status could generate dialogue and health-seeking behavior and integrated with technology. We looked more at the data, and Jacob mentioned the 6 risk factors that were 40% of disease. We later had a meeting here at the Institute of Medicine now 3 years ago on promoting health literacy to encourage prevention and wellness, where we presented the scorecard idea. And at that time, we had great dialogue and really support for the effort. I continued to help present this and hone down and write about it. And as you see at the top, we had cancer screenings and exercise immunizations. And in the midst of actually writing about this, Peter Anderson was guest editor of the Journal of Health Communication we did on communicating and non-communicable. He really suggested, well, we need to put in alcohol. So alcohol has been added, and because the standards have changed so frequently on cancer screenings and are very different in different parts of the world, we put alcohol, and we now have 7 numbers that are there. And we believe that the scorecard can help make a difference in that regard. The World Health Professions Alliance adapted this scorecard last year at the this time, and then later at the World Health Assembly earlier this year. And basically, that includes 7 risk factors as well, the similar ones that we've put on the scorecard. And just for those of you who don't know who the World Health Professions Alliance is, it includes the World Medical Association, the International Council of Nurses, the Federation of Pharmacists, the International Dental Federation, and the Physical Therapists Organization. All of those are 26 million health professionals, and they're working how they can diffuse a discussion item that might not be health literate at this juncture, but they're certainly working on making this available for their health professionals initially, and hopefully for individuals. So that's the piece that's evolved, as I just mentioned, with the WHO guidance numbers that are being used. The digital scorecard is the last piece, and I have about a minute or so left, so I'll just mention that we've been looking at how we take this scorecard for online and mobile, and there still is a digital divide for online, but mobile is bridging the divide. Mobile is reaching people at the right time, in the right place, in a personal manner. So we think that we can do a Score Your Health or Score My Health, or create a score that will help people know directionally where they are with risk factors for non-communicable diseases. And we've been presenting this at a number of places. And we've done this based upon some knowledge that we have thus far on mobile health. Just a moment, Text for Baby is a U.S.-based text service that we did in coordination with the White House. Now 700 non-governmental organizations, 420,000 women in the United States that have signed up to get text messages during pregnancy that are stage-based, that are very specific to health measures. We have some preliminary results that Ruth Parker published recently, and others, but HRSA is doing a large study of how it has both process indicators to get women for prenatal visits, and we have some good data that this has increased flu vaccine for pregnant women. The Mobile Alliance for Maternal Action is similar, but it's global with the U.S. State Department and USAID, where this is right now launched in Bangladesh and South Africa. Other countries are on their way. But we've learned with health literacy that a text message that somebody reads does not make a difference in Bangladesh. People need to hear it. So we have it in a local language where they can listen and pass it on. So all of these are informing better health decisions, informing health literacy. And my final slide just really brings all of this together. Checklists and scorecards can have major global impacts for patients and consumers. NCDs are a key place. The maternal and child mortality, we think there's great opportunity there. And even infectious disease, and particularly as infectious disease is bridging in some areas into prevention of chronic disease such as cancers. Better use of information through new technologies. This will continue to expand globally. And as the workforce is strained and growing, we nonetheless think that new technologies can empower the consumer or the informed patient or a more health literate individual. And then finally, the mHealth communication. I think that there's great promise. We have to think about using mHealth in the right way, both with mobile devices and information, but also as mobile devices will provide information that we can scale and measure and evaluate. So with that, I hopefully have given an overview. As you see, our roundtable spurs a lot of ideas. Some of these innovations we take into practice. I know there's people, and thanks to Linda for making this webcast around the world. I think there'll be lots of opportunities that we'll continue to hopefully share from today in the future as we hope to all make a difference with health literacy. So thank all of you here today and all of you listening around the world.
Thank you very much. It's very good to see all of you here today. And as George said, I work at the Centers for Disease Control and Prevention, which is part of a larger entity called the U.S. Department of Health and Human Services. So even though I'm standing here as an individual, many of my colleagues from other parts of the Department of Health and Human Services are here in the room and listening online. And I just want you to know that I don't stand here alone. There's a very large network of us who are very committed to making sure that health literacy becomes part of all types of health action. And so I just wanted to make sure that I acknowledge that there are many, many people standing behind the efforts that we're working on at the U.S. Department of Health and Human Services. So because I'm a communicator, I believe in key messages. And because I present to a lot of groups where people spend a lot of time on their mobile phones and devices, I like to give the key message up front, just in case people's attention wanders away. So the key message is that it is time to commit to measurable organizational change. And as Scott indicated, we have a very large and robust infrastructure that's been put in place. And I'm going to talk a little bit about that, how that infrastructure has been built here in the U.S. He indicated other places where that infrastructure is starting to be built in other countries. But in the U.S., we have really taken the approach of putting a lot of key pieces in place. And it seems that as a maturing field, now we're at that point where we really need to start bringing it down from the abstract to the concrete, because that actually is a health literacy principle. The more abstract you are, the harder it is for people to deal with what you're trying to present to them. The more concrete you are, the easier it is for them to understand what you want to do. And so really it is time to commit to this measurable organizational change in a very concrete way. So the questions that I will try and answer in my brief time is, what are the key developments in health literacy in the U.S.? How has the Department of Health and Human Services contributed to health literacy improvement? And where can we go from here? And admittedly, in 15 to 20 minutes, you can only be very high level in talking about some of these things. And you know, I do hope the report coming out based on the survey about U.S. activities will help flesh out this picture for you. So here's the image that I use when I talk about health literacy, this notion of a gap. And in some places, for some populations, under some circumstances, this gap can be even bigger than it's represented here in the bridge. But really this notion of a gap is trying to convey that and recognize that there already is a lot of communication, there already is a lot of information, there is a lot of education going on in the world already. That was acknowledged by some of our earlier speakers. It is taken to be a truism of the world that we live in. But what health literacy brings to this discussion then is, how do we go about communicating, and how do we go about educating, and are we really getting the maximum effectiveness that we can get from these efforts. So it's not saying that we need more communication necessarily, but it's saying we need different kinds of communication, different kinds of education that pay attention to the health literacy insights that are available to us in the literature if we look for them. So these key developments and activities that I'm going to run through here, again, this is just a highlight, and this is based on publicly available information. Many of the activities that are going on in the U.S. might be done by private sector organizations or organizations that don't necessarily publish on what they're doing. Again, the survey responses may flesh some of this out. But I do want to also talk about a few of the, after I run through some of our progress, I do want to talk a little bit about some of the gaps that still remain. So you heard reference to a law here in the United States called the Patient Protection and Affordable Care Act. And that, while it's not a health literacy law, does contain some important provisions for addressing health literacy, and even some that people probably did not envision when they wrote the law. So there are things related to patient-centeredness, for example, that Dr. Howard Koh and colleagues talked about in the Health Affairs article, that we can look to as an avenue for addressing health literacy. In addition, we had the Plain Writing Act of 2010. So 2 years ago, President Obama signed a law directing federal agencies to use plain language in all public communication. Now, again, that's not health specific, but that's something that we can use to push for addressing health literacy in our public health information. And finally, we have another law related to the use of health information technology. Again, not health literacy specific, but a law that is fundamentally changing the way that technology is being used to deliver healthcare services in this country. So in the last 2 years, we've had a number of laws that, again, have really laid this foundation for the work that we're doing here in the U.S. In addition, the work from the Roundtable, there have been a number of reports and publications that have come out of the Roundtable itself that have helped lay this foundation from a policy perspective. So 95 million, that's the amount of research that the National Institutes for Health has funded since 2004, just under the health literacy program announcement. So this, while it's a fairly large number, still is just the so-called tip of the iceberg, because there's a lot of other research that has been funded through other mechanisms at the NIH and through other mechanisms that many of us use, like contract mechanisms. So for example, at the Centers for Disease Control, we use contracts to support a lot of our health literacy work. Other agencies like the Agency for Healthcare Research and Quality also uses cooperative agreements and contracts to support work. So this 95 million is not the full extent of the research support here in the U.S., but that is the amount that's been supported through the official program announcement for health literacy research. Scott referenced some of the publications that have come out. The Journal of Health Communication has supported a number of special issues. This article that appeared in Health Affairs earlier this year on policy initiatives in health literacy that Dr. Koh was the lead author on, we were told that it was the second most read article in Health Affairs between January and June, which we were very pleased to hear. We had no idea it would be so popular. But I think that's an important step to point out that the literature has really built over time. There have been a number of bibliographies that have been published to show how the literature has grown. But really, again, that's part of this infrastructure, is that there's a very extensive literature that people can draw on and build on for implementation work. Health Literacy Online is an example of some of the guidance, the research-based guidance that's available to organizations. This is a very practical, hands-on guide that helps you apply health literacy principles to the design of health websites. And there's other types of things that like plain language manuals, and for the Centers for Medicare and Medicaid Services, for example, put out a very extensive toolkit on clear communication strategies. And so there's a number of these tools that already exist that organizations can use. We have national health objectives here in the U.S. They're called Healthy People. We're in our third decade. Is that right, Linda? Right? And for Healthy People 2020, we again carried forward our health literacy objectives and expanded them into health IT objectives. And we work with other parts of the Healthy People infrastructure to include health literacy activities under some of the more traditional health topics. So there was a reference made to the number of state-based activities in health literacy. And so on the CDC Health Literacy website, we have a map that highlights those states where we've been able to verify that there are health literacy coalitions or collaborations going on. So we continue to build that out. In fact, there are a couple of more states that are going to get lit up very soon because they're having their inaugural health literacy conferences this year or at the beginning of 2013. And so you can see that, interestingly, we have sort of this cluster right in the middle of the country. And there is a large number of states that have really been trying to build their own infrastructure at the state level to support a more collaborative approach to health literacy improvement. We have survey tools available, publicly available. This is a set of questions that are used to assess the quality of healthcare services, and there's specifically a health literacy module to assess providers' use of different health literacy and health communication strategies. And then finally, we have a number of robust health information services. Healthcare.gov that talks about access to health insurance information that the Centers for Medicare and Medicaid sponsors, Medline Plus sponsored by the National Library of Medicine, and healthfinder.gov sponsored by the Department of Health and Human Services. All of these are examples of publicly available health information sources built on plain language principles and trying to make information more accessible to all segments of the public. So while this does seem like a great deal of activity, you will notice that there aren't a lot of activities necessarily from the education sector. That still remains, I think, one of the most obvious gaps that we have to address. And we also do not have a lot of information to report on specifically on private sector activities, apart from the information that is available through the Roundtable meetings, which have been a great venue for learning about those activities. So you've heard reference to the National Action Plan to Improve Health Literacy. That's been out for a couple of years now. And the reason that we did the National Action Plan was, again, to provide a comprehensive framework that organizations could use to help identify their own priorities, their own strategies, to pull together a number of disparate activities that were very important in their own right, but did not have sort of a common framework and common goals. So we have 7 goals within the National Action Plan. They focus on how we create and disseminate information, on how we provide healthcare services, on how we educate people in our society, on how we deliver services through what we call community-based organizations and nonprofit organizations, how we work together across organizations and across sectors, how we conduct research and evaluation, and finally, how we tell others about the research and evaluations that we've done. So these are some of the areas in which we have had some impact through the National Action Plan. Go back. We've put health literacy on the national agenda by using the National Action Plan. We have heard from local organizations that they have a framework that they can use to connect their work to these larger policy issues. Having the National Action Plan has confirmed health literacy as an important health topic. It also provides talking points and benchmarks, project ideas, and conference themes. We've seen the National Action Plan show up in all of those different areas in those state-based and local-based activities that I've talked about. And also one other aspect is that it provides this glue for local coalitions. So organizations that might not think that they have much in common with each other, they can use the National Action Plan as a framework for then figuring out how they have common interests around health literacy. So I just wanted to show you a couple of examples of comments that we've received from people in the field. So from Health Literacy San Diego, which is in California, We heard from Beth Ruland, and she talked about how they use the National Action Plan as a benchmark to see how they, as a local coalition, align with national best practices and recommendations. And here's a picture of Beth and her colleagues presenting a poster on their work out at the Institute for Healthcare Advancement poster session. And then here from South Texas, here's an example of how they use the National Action Plan to identify key strategies and develop some community-level programming. This is an image of some workers at a manufacturing company that are learning about obesity prevention, and health literacy was used as a framework for designing that program. But this was, again, all linked to the National Action Plan. So where do we go from here? As I said, my key message is really about organizational change. So I work in a very large organization, as many of you may also. And so one of the things I think about is sort of how do I get my colleagues to think about health literacy in the same way that I do. And so that's really an issue of organizational change. It's not so much about health literacy specifically, but it's really about how do we as an organization change how we approach these issues to account for health literacy. So what I'm talking about is organizational change does have to happen at the individual organizational level. It has to happen within my organization. It has to happen within your organization. But it's not just enough for one organization to change. As you have heard from our first two speakers already, health literacy is a huge interconnected set of issues. And so we really need to think about sectors. And that's, again, why the National Action Plan was important, because it talked about groups of organizations as sectors and the change that had to happen within these sectors. So we need to look at the elements of organizational change. We have to look at research for these practice insights. We have to start using these off-the-shelf products already and not waiting for more research. And then we have to start tracking and reporting our progress. Right now, we really don't have a nice summary of the progress that we've made so far, and we don't have a way to track that progress going forward so that we can see where those gaps remain and where we need to do extra work. So thank you for your attention, and I appreciate your time.
Jennifer and I are very excited to be here today to describe the work we've been doing in Peru. As soon as I get to the right part of my microphone. The most exciting part about this is we have worked to improve hygiene in very poor communities, combining health literacy, microbiology, public health science, as well as, we believe it demonstrated a very successful public-private partnership by using both the strengths of Clorox and the strengths of Canyon Ranch Institute. Clorox Company was founded in 1913, so we are approaching our 100th birthday. We started making and selling Clorox liquid bleach. Today, we sell about $5.5 billion of products, and it's a very broad range of products over 100 countries.
You get the echo. Good morning again. I'm Jennifer Cabe, and I'm, like Suzanne, very pleased to be here to tell you about this health literacy program. Canyon Ranch Institute, especially as compared with the Clorox Company, is small. We have a global reach because of our partnership model. In every one of our partners, and we have 14, we have collaborators whom those partners bring in, as well as many of them, especially in the case of the Clorox Company, involved their employees. And so it's through this integrative approach to advancing health literacy that we're able to address what many people see as extremely challenging problems in public health, even some described as intractable problems. And we are able to do this not only through the partnerships, but by looking even beyond the causes of the problems to the causes of the causes. And that's what we'll be talking about a bit today. So then the question comes up, Why do these two organizations partner? Well, we have a mutual board member who said you really should be working together. And as all of you are looking to develop these public-private partnerships, I would encourage you to think about who are your friends, your champions, and how do you bring together these friends of friends to make something bigger happen. It's true that Clorox is a for-profit company. Canyon Ranch Institute is a nonprofit public charity, but our fundamental guiding principles, and this is what our board member recognized, our missions, our visions, our values are very complementary. We're both interested in improving lives. So you see the Clorox mission of we make everyday life better every day, and then the Canyon Ranch Institute, the power and possibility of a healthy world. Both organizations have the values of working well with others, in other words, partnership, and are very principled in all of our approaches. This made for an extraordinarily good fit.
So why this program? First and foremost, improving health is a priority for both companies, the nonprofit. Clorox, with Clorox liquid bleach, has a strong disinfecting heritage. Clorox liquid bleach has improved health and hygiene of people all over the world, both in water disinfection and in hard surface disinfection. And we have a number of programs where we're working on educating people on how to improve their health of themselves and their families through hygiene and disinfecting products. Canyon Ranch Institute, with their strong health literacy focus and their great skill at educating people, really made a great fit for what we wanted to try to do. And this program is perfect for the two groups because it does focus on hygiene and health, and it does focus on health literacy. So it was a perfect place to start our partnership. How did we partner? And some of these are some key learnings that we've had in our partnering. One enabler is to up front make it very clear who's doing what. So we figured out who at Clorox had the right skills and who at Canyon Ranch Institute had the right skills, and clearly outline what their roles and responsibilities would be. Second, we had an ongoing communication and collaboration. The working team had regular conference calls and occasional face-to-face meetings, and Jennifer and I talked regularly to make sure that we were giving consistent direction and messages for the people on both sides. Most importantly, we leveraged the strengths of both organizations. Clorox provided the funding and the microbiology, public health science expertise. We were in Peru, not by accident. Clorox has a very strong business in Peru, and we could leverage both our product distribution and business experience there. And then finally, we identified University of Arizona, specifically Dr. Kelly Reynolds, as a great partner for doing the microbiology research. Canyon Ranch Institute brought overall program leadership, very strong expertise in the social sciences and health literacy, and they identified Boston University College of Arts, specifically Dr. Andre Cuadros, as a great arts partner, as well as the local Peruvian arts and social science partners. Now this program, we call it Arts for the Behavior Change, is using the arts to help promote understanding of what people needed to change to get better personal and household hygiene, as well as how to use different products and disinfecting products. Importantly, this was an unbranded program, so this was not Clorox coming in and promoting Clorox products. This was talking more neutrally, letting the community learn and understand and be empowered to pick what products they thought were best for them and their families.
In terms of key outcomes, this is something that was a major focus of the work that we all did together with the collaborators Suzanne just mentioned, was that we were driving toward having measurable outcomes. And one of the areas in which we greatly exceeded our expectations for what we set as our prospective goals was attendance by the community members and participation in the 12 performances that we'll tell you about in just a moment. We measured knowledge and understanding. There was increased uptake of both, and also changes in actual behaviors. In addition, we'll tell you a bit about the improvements in the microbiological burden in those areas that were targeted for the communities that were selected. As Suzanne mentioned, Clorox has a strong business in Peru, and the decision was made that we would work in these shanty towns, which is not a pejorative, that's the term they themselves use in describing the communities. In November of 2010, a team from Canyon Ranch Institute, Boston University, and the Clorox Company went and did site visits at numerous communities, numerous shanty towns around Lima. And as you can see from this slide, there is tremendous need in the communities. That's an actual image from one of the communities that we did work in eventually. We developed together, among all of the collaborators, a set of criteria for selecting the communities we would eventually work in. These images we thought were important to show you because, in particular, you'll see over here on the right-hand side the young woman and the little girl who are taking water using a pitcher out of a large blue barrel. The water in the communities that we worked with is only delivered through this method. There's no plumbing. So if you can afford to purchase water for your family, it is delivered through these blue barrels. And as you can see, the blue barrels aren't clean, and then the buckets that are receiving the water aren't clean either. So the water comes dirty, and it is then used, and it's sort of the in-between of after delivery and then what happens in the use of it that we saw an opportunity for tremendous advancement through health literacy. As you can see from this slide, the program design was intensive. There was not only a formative assessment and a pre-post design that was conducted through interviews and observation. There was also a process evaluation throughout the 12 performances over 11 weeks, and the performances were a telenovela style. The microbiological work was done formative as well as pre and post, and there's a whole lot more detail, of course, that went on in the program, including workshops and ways that we promoted the performances to get the high level of engagement and attendance. We would love to answer questions about that. Time simply doesn't allow today, but you'll have our emails and you're more than welcome to contact us. I should also mention that all of the work for this program, from training through performance and including all of the evaluation, was done in Spanish, and of course that was in Peruvian Spanish, and in particular the Spanish of the shanty towns we worked with there in Lima. One of the most interesting aspects of this arts program that used health literacy to improve household hygiene was that we had the opportunity to work with a community of people, in particular the arts community, actors and singers and puppeteers and dancers, who had the opportunity over a 2-week workshop in Lima to learn about germ theory. And microbiologists from the Clorox Company and from the University of Arizona came in and taught everybody about microbiology. And during that time as well, the health literacy aspect of what is it and how do we use it and how is it different from what you may have seen of handing out brochures in neighborhoods. And that was Dr. Andrew Pleasant, who led the health literacy training for our arts partners. We also, during this 2 weeks, outlined the first 4 episodes of the telenovela. However, there was constant change in all of the episodes because of the interaction of the community, which you can see here a bit. The key thing that we really do want to emphasize when talking about doing this type of partnership is that it was so important for us to really engage and honor the existing leadership structures in the communities where we were so privileged to work. That was really critical. There were a lot of lessons that we learned along the way. One that we've got some fascinating data about is when we didn't engage as much with the community leaders, the structure there, we did not have as much success. So the performances, just briefly I'll tell you that The play was called Siempre, which translates in English to always, as in always sick. And there were two families that made up all of the characters the actors portrayed on the stage, the Maranas and the Buendias. The Maranas means sort of maybe disorganized or even messy. Buendias means the good days. And each family, however, had some of the opposite characteristics in them too. So this is the sort of tension that helped to drive along the narrative. And throughout all of the 12 performances, the community was extremely engaged, coming up on stage, asking questions, even replacing the actors up on stage if they wanted to say, here's how I really think something should go. For example, around about episode 7, I believe, one of the beloved characters died. It was a little girl who died, and the community did not like that. And so the joker, the facilitator, who's a physician, Dr. Jose Vignoles, also a community health expert, stood up and said, all right, so you know enough now, maybe we could have prevented the death of this child. How would that occur? And then the community stood up and explained how that could have happened. And the little girl was brought back, which meant a lot of rewriting for the writing team, but that was okay because that showed the engagement that was really occurring. This slide is merely to show you one of the beautiful pictures of the interviews that were happening as part of the process evaluation. This quote also indicates the very high level of positive feedback that we received about the value of the program in the community. Now with these numbers, we're starting to get to outcomes. You can see from these that we were successful in having people learn and make changes that were very much brought forth through the performances. In particular, you can see that nearly 100% of the respondents were aware of the performances, and nearly 58% had made changes in their own homes because of the intervention, because of the plays that they went to.
Where the behavioral outcomes were very strong, the microbiological outcomes were more mixed. And that is the overall microbiological load was very high, both before and after the performances. This is largely due to the high poverty level of this community and the openness, so it was very hard to control any given area. This picture shows part of the problem. That is a bathroom in the community. So it's very hard to control any of the microbiology as a result of that. The second big learning we had in this was that the microbiology team needed to be much more closely linked to what the performance messages were to make sure that we were testing before and after the same areas that the performances were highlighting. Even given all of this, we did get some positive improvement in the overall decrease of E. coli and Listeria. The biggest improvement was in food preparation areas, which was one very large topic in the performances, where we did see less samples, almost a third less samples that had any E. coli or Listeria in there. So this does show that there was some change. In future work in this area, we do plan on adjusting exactly how we do the microbiology. So in conclusion, this pilot did demonstrate the effectiveness of this approach of the community engagement and using performing arts to advance health literacy and improve health-related behaviors. We've also demonstrated the power of a public-private partnership, and one of the things that we believe makes this partnership particularly powerful was it's not just Clorox funding a nonprofit and them going to do the work. It's both groups bringing in the best people that they had to be able to collaborate to come up with a really unique and effective program. We believe that this is a very good way to improve public health, and it would be a great add to many different communities and cultures. So our next steps is we are looking right now is to where and how to best scale this program, trying to expand by finding additional funding and making sure that people understand what we've done and what we've learned so that we can continue to go after these very tough perhaps intractable, but we believe that we can make a difference if we all keep working together in this area. And I'll leave you with the quote from one of our community participants. We are so lucky to have this program in our community, so everyone should come. Thank you.
So thank you to all of to this panel. It was a terrific panel. And now we'd like to have some conversation before we have about 15 minutes for that, so, or actually more than about 20 minutes for that. So we're now open for comments and questions. There are a couple of microphones out there. You'll see them in the center there. So if people would come to those microphones and actually form a line, that would be terrific, because we can make use of the time most effectively if we do that. And go right ahead, please. Identify yourself for the folks on the webinar, if you would, please. I think so.
This is for Dr. Ratzan and Kumaresan. Given all the discussion on mHealth, are there any analytics being conducted on people who actually read, comprehend, and act on text messaging?
I'll first answer quickly that we published a journal supplement of mHealth in June this last year, and it has a whole variety of everything, including whatever lit review has been out there to date in developing countries. I think Jacob, and I'll let him speak more about the smoking cessation piece, but clearly both the Lancet article clearly shows how the mHealth for smoking cessation can make a demonstrable difference, and many populations are scaling that one up. There was also one in JAMA in April on text messaging for vaccination amongst adolescents, so it was a different target population. But I think we have enough proof of concept that's starting to show that there is actually uptake and appropriate messages when they're delivered by a trusted source. So I think the communication principles are certainly there. The mHealth literacy piece, I think, is continuing, and Jake can speak more, but we actually have an eHealth and mHealth working group as part of this innovation working group with the Secretary General's office, where we have WHO, ITU, UNICEF, variety of academics, and anybody here is welcome to join that as we're trying to help inform and, frankly, connect the dots. For those of you who work in both the UN system and government groups, you know that oftentimes things work in parallel, and we're doing our best to try to do that as well. Great question. I think we need to continue to have it. And the last aside is there's an mHealth Summit that the NIH hosts this year in December. Every year it's grown. I understand there's going to be 5,000 people going this year, so there's lots of opportunity.
Great.
Yeah, just quickly to add on, as I mentioned in my talk, this M cessation program is very good. And there was a publication in the Lancet which said that there was doubling in the quit rates within a period of 6 months in the 5,000 participants as compared to the control group. I also wanted to say that this is a wonderful way to outreach. In 2010, when we had the World Health Day on urban health, we could not reach people in Somalia. So working with a Vodafone company, they were able to send 1 million text messages to Somali residents. No? And this is unbelievable. And just working with the kind of partnership, public-private partnership, we can do this. And it has to be constant, of course, and sustainable and scalable and so on. But it is possible. And the last point is that we need to measure it. We need to have metrics so that we can understand how much of this is having effect.
Thank you. Let's go to the back microphone, then we'll come to you, Will, and then we'll go back again. So go ahead.
And I was, like Cynthia, an associate director of communications, and I was in the White House Office of Management and Budget. And I'm interested in the U.S. definition of grade level for written materials, and then whom do you turn to determine if your written materials are at that level?
That's you. It's the U.S. definition.
You're talking about U.S. or UN?
U.S.
Well, we do not target reading grade levels, and that's sort of a long-standing decision that we've had. Some colleagues might have a different view, but in general, we do not target reading grade levels because we think that communication is a far more complex process than what a reading grade level represents. Some people use it as like a comparative tool among materials, but not as a measure of comprehension or understanding of information.
Oh, Will?
Will Ross, a Roundtable meeting member. This is to Jacob. Really appreciate your comments about rights-based approaches to coordinate health literacy interventions globally. I find that intriguing because one of the things we want to have as an outcome of this conference is a method of identifying practices that could be actually implemented at the grassroots level and sustainable over several years. And the best way of doing that is really having it codified or enshrined in constitutions and political documents. That's terribly difficult. And so you gave a couple of examples of leading countries are actually delivering health interventions, but in terms of utilizing this human rights approach, really making sure that it's done so in a manner that allows those countries to be held accountable for an outcome. I mean, can you give us an insight on which country or what direction we would be countries should be going in order to ensure that they can indeed have that type of codification of rights-based approaches to health literacy interventions?
Well, I think one of the best examples for us recently is the Framework Convention for Tobacco Control. This was implemented in 2005 and came into force in 2006. Within a period of 6 years, 175 countries have signed on to this, which is wonderful. I think this is the only first public health treaty in history. Of course, application is different, and every year we monitor how much of the framework, how many articles have been implemented, and so on. It takes a long time, but I think we need to use these kind of mechanisms to ensure that countries can adapt to their own circumstances and then be held accountable. And it's not easy, you know. You probably know that Australia was the first country about a couple of months ago which went into plain packaging. And it took about 3-4 years of effort to get it done. No? But other countries will follow suit, probably New Zealand and so on. No? But we need to use these kind of successful models to ensure that what is there in UN resolutions and WHO resolutions can be implemented, but it takes quite a long time. No?
Thanks. Right.
Hi, my name is Allison McEachran. I run the Business Council for the UN, which is a program of the UN Foundation. The panel raised a lot of great examples, I thought, of private sector collaboration and involvement with NGOs and UN agencies, et cetera. And I just wonder if the panel might respond, where are the gaps? Where are the opportunities, the biggest ones that haven't been met or filled yet for the private sector to collaborate with the UN and UN agencies in ways to help meet the goals of the health literacy group? Thank you.
Go ahead.
I'll try to take that quickly. And I'm looking at the brochure that we have on the Innovation Working Group, which includes private sector. We have 70 leaders, 5 health foundations, 6 academic institutions, 10 NGOs, 11 government organizations, 12 UN organizations, 24 private sector businesses. And we've been doing a lot of other pieces in terms of we have financial groups on there, we have other groups on there from health and delivery. One piece that's missing, and one piece that's always a challenge, I think, is the media. The media not just as the conduit, but the media as an ongoing purveyor of health information. And I'm not saying that we need to do that in a systematic way, but it would be good to figure out ways to step up. We have some good resources with the cellular telephone group, the CTIA in the United States and the GSMA globally that's now working to scale up some mHealth pieces. But some of the intermediaries, frankly, are the sectors that might not necessarily be always a party to health, but maybe they're also hearing this from others. Also, I think that fundamentally the world is changing, that the public-private partnerships that we heard here today, some governments are still open to more work with the private sector, but everybody is not open to work with the private sector. So we have to also be cognizant of the private sector is not all the same, and high, rational, trustworthy, ethically based companies, I think, are key to part of this as well.
Can I just make one
Please
comment
go
on
ahead.
that? Yeah, so this is not necessarily on the gap in partnerships, but I mean, this might be one outcome of a public-private partnerships is I think we need some more transparency, some more information about what's going on in the private sector, because I mean, I understand from a competitive perspective and from different business models, the private sector organizations may not be as open as other organizations for sharing information, but it does make it hard to know what's going on if there's not more transparency in this process. So one possible outcome from public-private partnerships might be transparency across all kinds of activities and projects, because I think we just don't have enough transparency and openness to know what's going on in some of these organizations yet.
Jennifer or Suzanne, do you have any comments on this point?
Yeah, I think that all the points that have been made are good ones. The real key is the sort of balance between, we did this program unbranded, but we do have a very strong business in Peru, is this balance between pushing commercial interests with also doing the right thing. And there's a couple of issues. One is trust. Do you really trust that we're not just out to make a lot of money? As well as making sure that the company balances their own business interests. But I do feel that with the right companies and that do have strong foundation in sort of high integrity in these types of activities, there is an opportunity to dial up the benefit of partnering across public and private partnerships.
So one follow-up question that I'll take the liberty of asking. Can we assume that the nature of public-private partnerships is the same for different countries around the world? Anybody care to make a comment on that?
Well, not even close to being the same. And there's even movements amongst academics here in the United States. Michael Porter and his group, FFG, have been talking a lot about shared value and moving from a corporate contribution model to a shared value model. There's different models of how companies approach this, and even our company in the 190 countries that we're engaged in. So I think they all need to be culturally sensitive and addressed by local needs and resources.
So we'll go to Winston, and then we'll come to the front, and then we'll go back and forth here. Winston?
Thank you. I'm Winston Wong, Medical Director, Kaiser Permanente, and also a member of the IOM Roundtable on Health Literacy. I very much appreciate this last presentation with regards to the initiative in Peru. I think it's great work. And I also appreciated the first few presenters, their comments around the importance of integrating health literacy into real policy. I think the question that came in my mind in terms of hearing these two different aspects of the issue is around scalability. And I think I heard that policy recognizes that ultimately health literacy efforts get most traction at the local level. But at the same time, how do we think about scalability in terms of local efforts that have been successful, and how you bring that in terms of either performance metrics and or infrastructure and resource deployment so that we get a level of scalability that we can really make global impact.
Comments on scalability? Why don't we start with the folks from down at the end there?
Sure.
Suzanne or Jennifer?
So that's the question exactly. Thank you, Dr. Wong, that we've been asking ourselves a lot among the collaborators in this partnership, which, yes, started in Peru with the very intention for it to be the Arts for Behavior Change program pilot, demonstration pilot, the test case, to see if our ideas would pan out in any way. And we're both surprised and delighted that things panned out even more in some areas than we expected. As Suzanne mentioned, we did learn from this intervention that went on from September of 2011 through December of 2011, and then followed up with a lot of the evaluation. So it's very, very fresh and recent. Some of the analysis is still being conducted and sliced and diced in different ways. But we learned a lot of things about what we can do better. And among those is better use of resources to get to our end goals, and better use of early on the interaction with the communities, interaction between the social scientists and the microbiological researchers to get to empowerment for all of the parties, because the more empowerment is going to really drive you to the outcomes, is what we saw time and time and time again. So what we're looking at now is scalability in the form not only of taking everything we learned and looking at, okay, well, how many performances do we really need, for example? And we've already figured out a lot of the little tricks and stories and things like that to make people come to the performances and get engaged. But then also, how do we use technology, which is mentioned a lot by many of our colleagues on the panel, but can we use radio and TV and set up even videos in, say, market stalls, whether that is in Peru or in other countries. We're talking about how to bring it forth in the United States, perhaps, in communities here where people gather to go to big retail centers. How can we tell these stories that is done in a really health literate, engaging manner, and do it in a way that is going to reach a whole lot more people than we reached in these communities in Lima?
Cynthia?
Yeah, I think about scalability a little bit differently. I mean, there's scalability in terms of the number of people that you touch with a particular project or intervention. For me, scalability is in the context of large organizations. So, for example, it's not enough. I mean, my problem with scalability would be if I could get a team in a branch, in a division, in a center to do something, that would be very slow if I had to go team by team, branch by branch, division by division. So my approach is to say, what are those large-scale activities already happening in my organization, and what's that change I need to make within that activity to then affect thousands of employees and millions of dollars and hundreds of programs. So for me, that's how I think about scalability. So one example that the Health Resources and Services Administration, which is a sister agency to mine, we both have taken the approach of looking at our funding mechanisms. So they're called funding opportunity announcements, or FOAs. So we've gone after these structures of FOAs because those are the announcements to the public about solicitations for proposals for funds. If you insert health literacy in plain language and cultural competence and limited English proficiency into that template, you have suddenly affected every single program that now uses that template to request proposals. So that, for me, is how I think about scalability, because I think I'm now I'm touching millions of people potentially, but I'm also touching hundreds of programs and millions of dollars that way.
And comments from the panel on international scalability. Scott or Jacob?
I think Cynthia is alluding to moving from local to social change. And I think that's what we really need for health literacy, is how we integrate, and I believe we can integrate new tools that will help for social change for the scalability. So the challenge that we've already had, which Winston's question is the $1 million+ question, how can we scale even checklists? And very quickly, with the international group getting around this, the UN and now this Norwegian and Nigerian-led Commodities Commission, they have in there next year 5 countries, and by 2015, all 74 countries that have mortality below a certain level. These are stretch objectives, but just like 20 by 25, just like 5 or 5 for HIV, all these other pieces help set goals that I think the international community could come around. And then also, I think we need to be clever of even bilateral relationships of how we have the scalability and existing mechanisms that already work. Notwithstanding Millennium Villages that are worked on up the road by Jeff Sachs and his group wanting to take the scorecard and under some of these ideas, but also figuring out what tools we can continue to embody with the whole mHealth area. We really need, and I believe the health literacy world needs to really help get this one right. I think there's great opportunity to do it right, as Jacob and others have already said here today. So lots to do on it.
Any additional comment, Jacob?
Very quickly, I think there are 3 factors required for this. One is to show the effectiveness of the initiative. The second one is to get the community to understand the value of that. And the third one is to have a national policy which helps the community. Let me give you a quick example. In 2006, I was involved with the trachoma project in Ethiopia, and it's a partnership with the Carter Foundation, and Pfizer gave the drugs and so on. One of the elements was water and sanitation and hygiene, and to build a latrine so that people understood the need to wash hands and so on. The Carter Center target was 10,000 for that particular community. When we went there a year later, we found that there were 92,000 latrines built in the community. They saw the value of this. The kids did not have trachoma, eye disease, they didn't have respiratory illness, etc., diarrhea. So women decided to have one toilet per household. And when we actually went and saw this, President Carter was asking them, what do you need more? And you know what they said? Now our children are healthy. Can you please build us a school in this place so our children can go to school? This is where the community understands the value of your intervention, and it can just go to scale. And today I can tell you that this is a policy of the Ethiopian government to have one latrine per household. So it can be done.
So thank you, Winston, for that key question on scalability. We spent a little time on it, and I'm glad we have. We have 4 questions and just a few minutes in this session, so we're going to limit these 4 questions. You're next, and then we're going to go back and forth. Go ahead.
Yes, I am Len Epstein. I'm with the Health Resources and Services Administration at the U.S. Department of Health and Human Services. And I'd like to ask our outstanding panel, how can health literacy more effectively integrate cultural and linguistic competence and how can health literacy more effectively integrate cultural and linguistically appropriate health and healthcare perspectives? I heard that there was skirting around this issue, but I'd like the panel to more target this response. Thank you.
Well, Len and I work together a lot, so he already knows what I think about this, but I'll make a few remarks. I mean, literacy is obviously a culturally specific activity, so I mean that's kind of the first level observation. And so to kind of think about what it means to talk about literacy in particular contexts, I mean you're already talking about culture. I think in terms of the sort of broader framework, I think that's where health literacy has to connect back, as Scott alluded to, broader health communication principles, because there are things above and beyond perhaps health literacy that we need to take into account from health communication, health education. I mean, limited, in the U.S. context, we talk about limited English proficiency, and clearly there's some specific things we can do from an accessibility perspective, and I think we're trying to do that. So, for example, there's a push within from the Department of Justice, which is coming down through to the other agencies, on language access plans, on agencies having robust language access plans. So that's a very, again, concrete place for us to marry up this issue, this kind of more traditional notion of providing interpretation and translation services with the broader notion of understanding. So it's one thing to provide the service, it's another thing to have that service result in people having a better understanding of what that encounter was just about. So I think there are some places like that where we can integrate them more directly.
Back microphone.
Hi, my name is Ufara Zwasti. I'm from Indonesia. I work at the Office of President Special Envoy on MDGs, so I'm here with the Indonesian delegation for the UNGA. I would like to share about what we are doing in Indonesia. We are building a integrative health intervention program at the 7 pilot areas to reorient the primary care system that aims at community empowerment and health literacy. We work together with so many sectors, private, government, NGOs, CSOs, etc., including Nokia Life, because like we've been talking about the mobile tech. So we got Nokia to build us an MDG app that will be given first to the women in the areas. The tags are very highly personalized because we think we cannot just send broadcast text messages to people without having them personalized. Like for example, like in the first app of the app, there's a question like, are you a female? How old are you? When is your last menstrual period and stuff? And then it will direct the user to the appropriate information. Like for example, the app counts that you are 7 months old pregnant. So they will give you the appropriate information that you need. So that this project will be scaled up to the national level. Nokia actually already did it in Nigeria, and they said it works. So we want to see whether it works in Indonesia. Hopefully it will, because Indonesia has like about 240 million people, and I think like 80% has mobile phones. The other thing is, I would like to ask how to best engage the local governments to continue the programs that are already made from the public-private partnership, because when I surveyed the locations that actually want to be implemented this intervention, the interventive health program, their first question was always, where will be the funding from if you go away? Because we've been having lots of programs that are very good, like people's behaviors are changed drastically, but when the fundings are gone, the programs will just be a monument. Because I think in PPPs, public has to be the stronger part than the private, because the private cannot stay forever. But my question is, like, I cannot answer them like very clear, like how to get their local government to actually fund it, like whether the funding is the most necessary thing in giving people the program or not. Thank you so much.
Thank you very much for that just compelling example of the power of mobile health in Indonesia. And then the question of how do we sustain programs after the initial program is complete, and how do we get good funding models, local sustaining funding models for them.
I'll just try to address it briefly and just mention we have a lot of this discussion when I used to work at USAID that are usually 5-year cycles, and the idea that when you start something you would also want to hope to have an exit strategy so you leave some sustainable change that will help make a difference, and hence the idea to move from behavior change to social change, even with health literacy being integrated. But to use your specific example with Indonesia, we've also been involved with a lot of the mobile health area, and Nokia may come in with some sort of business model that they want to get people connected. There may be some ways where with the tech side you have both the cell phone provider as well as the tech, the people that are in the industry, the wireless industry, to be able to figure out some way, just as there's public service announcements, whether you call them universal service obligations, or some other way that there could be ongoing ways to continue that once the years have developed to get the evidence right of how to approach it. So I would say try to build that into the business strategy early on, and also have the social good that has the local programs that have local ownership, that it's not a north to south, and hopefully a south to south piece, as you mentioned, with Nigeria. There's lots of evidence that's coming out of Indonesia with other support for midwives. There's lots of organizations around the world looking at cell-based technology there, also with the geography and the 240 million plus as mentioned. So I think you do have potential for sustainability once your funders may walk away.
So I think we come down to the front microphone, and then we'll take the last question here before we take a break. Go ahead.
Thank you very much for all the panelists. I'm Diane Levin from Israel. Just two quick comments, questions regarding public and private partnerships. Regarding the partnerships between public institutions and private, at least in Israel, for example, we're required to open up the partnership to anybody who would like to partner, particularly when we're looking at the private sector. And then those who come back and say that they were interested, and we have criteria and all, so that way we are able to work around the ethical questions about having one company or one private investor, and whether there's branding or isn't branding, there's always an ethical question. So we found that that was successful, and I wonder if our public partners here had any experience with that. And the second point being, to what extent do private partners then, in your experience, have been asking themselves or requiring from themselves to also have a health promotion or health literacy agenda within their companies, among their workers? To what extent does it stop with the program that they're promoting, or is it internalized and also implemented within the organization that's partnering? Thank you.
So I can start. So a couple things. I haven't seen this open idea, and I don't know how well that would work. At least, we belong to a very competitive industry, and there are certain companies that we wouldn't want to be working with a nonprofit, because we'd be worried too much about sort of teaching each other secrets, as well as antitrust issues in the United States. So I don't know that that would work so well. My other experience in partnering, and I do broad partnering for Clorox, not just this type of partnering, is cultural fit and value fit is extremely important. So being able to make sure you're working with the right people is a huge enabler to being successful or not successful. In terms of your other question, Clorox does have a very strong belief in health and wellness, and it permeates the entire company. So in addition to the work that we've done with Canyon Ranch Institute, we have a very strong partnership with Red Cross and disaster relief. We have very strong community outreach programs in the communities that we do business in, both through education and health. And within the company, we have extremely strong promoting health programs, online programs. We use a lot of mobile technology, multiple languages to reach different speaking employees within the company. So I think that we do actually live what we preach across all aspects. And I think it's important. If you're not really living what you say you believe, I don't think you can be as effective.
I'll just quickly add it. As Cynthia mentioned, transparency. At Johnson & Johnson, we publish a sustainability report, and amongst that we have a health literacy goal of 100 programs in 25 countries by 2015. This is something that we publish against, we report to the street, and so forth. So I think the more companies can engage in a public way in their annual report, and Dr. Isaac will talk later about, we measure our number of our smokers that we have and hypertensives and so forth. There are ways that this can be done, and the more transparent companies could be, the more they would report, and the more they would set these targets. And that's part of a Healthy Futures 2015 piece where global health is part of it. Everybody doesn't think the same way.
So this question highlights a key issue, and it's also an issue in healthcare delivery as well in the Twin Cities. And I would notice that in different markets in the Twin Cities, at least in this country, there's different levels of the sense between what is common and what is collaborative and what is proprietary or private. And so that borderline between respecting the private company's sort of sense of one, not violating the law, but two, what can be cooperated with, and that common sense is an opportunity in terms of exploration with the companies involved to get the maximum sort of balance that's comfortable for the participants. So that would be my personal comment. You have the last comment before we break.
Thank you. My name is Sabrina Kurtz-Rossi, and I'm principal of Kurtz-Rossi & Associates, a small women-owned business in Boston, Massachusetts, specializing in health, education, literacy, and evaluation. So my question, my interest is in supporting professional development and organizational development of the field of health literacy. Our field is growing over time. We really are getting to a place where we have folks who really identify themselves as health literacy professionals, but we also have a field that there are people from a lot of different professions that identify with health literacy, folks in librarianship and nursing and pharmacy and health plans and all kinds of professionals out there from different kinds of sectors and organizations. So how can we, I'm a little concerned that the NIPL Health Listserv is now, that was one way of kind of using technology. We're using a webinar today, which is great, to kind of get information, best practice, you know, out there, that information out there, and connect people and build collaboration. So how do we utilize technologies or create some kind of a place where folks can share information, share tools, build collaborations? I know, Cynthia, that, you know, you have a blog, but there just seems to be a need right now for some kind of a, I don't know even what you would call it, but a way to learn from all of our partners and share information, both, you know, nationally, but also internationally. I know there were conferences in Canada that I've, you know, been to, in the UK, and we've got research conferences in the US and practice conferences. How do we connect folks so that we can share best practice and establish even basic competencies for health literacy professionals out there? I think that's a question for everybody. Utilizing technology, you know, your blog, how do you share tools, how do you build collaborations? I think it's a question for the whole panel.
Well, so I'll just observe that when we launched the cdc.gov/health literacy website, I guess about 18 months ago now, I actually put the links to the international activities that I knew about and could confirm on the homepage. When I looked at the traffic data, it was non-existent. Nobody was really utilizing that information. And what people were looking at was our state-based data. So that was telling me that the traffic was primarily coming from within the US, or if people were coming from outside the US to look at this, they were still looking at the state-level information. So I moved the international links are still there, they're just like on a second-level page now. I have been writing the blog now for a number of months. I rarely get comments from people on the blog. I see that there are people reading the blog, but I don't see many responses. So I don't see the professional information sharing that a blog is supposed to generate. So please, write to me about the blog. So I have tried to position the CDC Health Literacy website as that information sharing place. I'm happy to do that. I mean, we are a government agency, we have public resources. I see that as part of our mission, is to help share that information very broadly. But I need to hear back from people about what they're looking for, what they need, what we've done that they want to see expanded, and I'm just not getting that feedback. We also have a health literacy mailbox associated with the site. You know, usually the feedback that I get there is somebody who's telling me the online health training program, you know, there's a glitch or something. That's usually what I hear from people. So I think you're right. I think there's a huge opportunity. You're right that the action for the most part has been on this listserv funded by the Department of Education. People have felt more comfortable, frankly, I think, with that technology than anything else, because it comes into their email, it's easy for them to respond, they can quickly throw an inquiry out there, and it's, you know, very low cost to them. So I think it's in part what professionals, frankly, feel comfortable with in terms of their own communication practices.
Hi, Sabrina. This is an excellent question, and I think this is the opportunity to mention that the IOM Roundtable on Health Literacy made a decision, a very good decision, in deciding to commission a paper based on a tremendous survey. They asked Andrew Pleasant to put it together, and there's now this compilation, this report, that brings together what is happening in policy and in programs and in research, and encompasses all of the responses that were provided from around the world. And then the next version of the report is going to focus on the United States. So that will perhaps, in addition to what Cynthia was just mentioning, be another tool for better understanding what's out there, how are people being trained, as you ask, and then what happens with that training to advance health literacy and improve health outcomes.
Thank you very much for drawing attention to that. Scott, go ahead.
I'll just briefly mention that I think it's a great question, Sabrina. You're asking everything in health literacy, and I think we need to narrow what fits right with CDC, what fits right with IOM, what fits right with the journal, as we publish a research supplement every year. But I think there's an opportunity, and I really would like to hear from others who've been in this field for quite some time, of how we advance this from a communication standpoint, because we're really talking about a network of individuals that have a variety of of research and applied interest. And I think one thing I should put on the table, and anybody in this room can contribute, is next year, or currently USAID is doing an evidence-based summit on social and behavior change communication. And amongst that, there's health literacy. And next year, some of those recommendations will be not only what's happening in the US, but this is also with 300 experts in this field of gathering the information of how to better disseminate that and put in a communication arm to it. And whether health literacy becomes one of those, I think also depends on how strong we can make the evidence here in the global community. So there's lots of opportunity. We have pieces that already exist, but we don't have to reinvent a whole new piece. We just have to better use the tools that we have.
Thank you.
Thank you very much for those comments. I just have to note that Cynthia and your comments, pointed out that there's your central message that it was the time to commit to measurable organizational change, moving from the abstract to the concrete. And then Scott, in your presentation talking about checklists, mentioned that you added tobacco abuse or tobacco use to the checklist, the prevention checklist. And it occurs to me that one way that organizations ought to be thinking about health is through this larger social determinants model. Mm-hmm. And it seems like each section could use with a checklist of the top key issues by that model. Not only preventive care, but the top behaviors by country, and then obviously how that organization relates to the other determinants. Might be a way to further that idea. Perhaps you've already thought of it, but certainly be an interesting way to advance that. So you'll notice that we're a bit behind. But I felt it was important to do that because of the importance of the conversation to these events. So what we'll do is we'll take a 10-minute break and reconvene at 11 o'clock. Then we'll be about 15 minutes behind. And at that point, I will intend to take a little of that 15 minutes out of the lunch break. So that'll be our plan. So we'll convene in about 10 minutes at 11 o'clock.